let's start with just a practical one. You'd mentioned that the immune checkpoint inhibitors are given basically on a continuous basis. Is that because we can, or is there a compelling reason to think we should do that? And have we learned anything from experience thus far in patients who have stopped either because protocols have said to, or they've stopped because of side effects and yet continued to do well? And I'll start with you and others if you want to.
So that's a great question. I would say that the answer is actually we don't really know for sure yet. With the drug ipilimumab, in some of the clinical trials, they actually kept giving it out into the future, but when it was approved, the FDA decided there wasn't enough safety evidence to keep giving it. And in retrospect, some people argue about this, but it seems that most of the benefit comes from the first 4 doses, and therefore we do feel confident that 4 doses is enough of ipilimumab to give. With the anti-PD-1 and PD-L1, to me, it's not clear yet whether or not we should keep giving it forever, or if there is a certain amount of time we can give it. And I think the future is going to be trying to figure out what in the individual patient can predict whether or not we can stop it and the cancer won't grow back.
Others agree?
Yeah, I think that without question, a large proportion of patients who've responded to PD-1 pathway blocking agents, when you stop them, those responses continue for long periods of time. But some do recur, and so at this point we don't understand why that happens, and yeah, I agree. I think clinical trials are going to be important to determine which is the best way to really ultimately deliver these, particularly for some of the less toxic of these antibodies.
Question about where does immune memory reside if these cells have a finite life and yet the memory is perpetuated over time? Is that known, that that there's some continuous generational passing on, or is there any place like the thymus that is the center of memory?
So it's likely that there are 2 places that memory cells live. Originally, they were thought to primarily live in the lymph nodes. More recently, there's been a lot of interest in the fact that probably the larger proportion of memory cells actually live in the tissues themselves, and those have been called tissue-resident memory cells, and they have particular markers. So by analogy, I would imagine that the relevant memory cells in cancer may actually be living directly within the tumors themselves, the tumor equivalent of the tissue-resident memory cell.
Practically speaking, we'd heard a bit about interferon and IL-2 along the history. Particularly with IL-2, that has been known historically as one of the first examples of a minority of patients getting a prolonged benefit, but at a toxicity cost, certainly. Has that really been obviated by these newer developments, or is there still a place for some of the older immunotherapies that still that got us to this point?
I might best defer to the melanoma.
Okay. Well, I would say I think absolutely there is still a role. There are a lot of things in flux now with the role for anti-PD-1 and PD-L1 antibodies, and that's going to change a lot of things. But there are certainly patients who get ipilimumab where it doesn't work, and prior to just a few months ago, they couldn't necessarily get anti-PD-1. Those patients were referred for IL-2, and it does have a toxicity profile, but I've certainly had patients who had long-term regressions as the second-line treatment with IL-2. So given that we know it can work, I think there is still a role for it. How that will play once we have anti-PD-1 easily available, I think we don't know yet.
Yes, I'd add, too, that there are clinical trials that are investigating using PD-L1 therapies in addition to interferon and trying to identify whether those can be synergistic. So I think it is an open question.
We have several questions about PD-1 and PD-L1 inhibitors. And just as a basic premise, are there practical differences that have emerged in terms of the ability to induce memory or activity where one might be more useful than another, a value in combinations, or is it just an unknown yet that will be defined over the next decade or more?
My experience has been that I'm not sure. I think that's an open question. I think in larger studies, the response rates in various diseases have been relatively similar. None of them have been compared head-to-head to one another, so I think it's certainly premature to say that one might be better than the other. Anecdotally, it's possible that the PD-L1 drugs in combination with CTLA-4 have had a bit less toxicity, but that's incredibly anecdotal. So I think it's an open and important question.
I'd just add that it may vary somewhat by the type of cancer also, and we don't know that yet. So making broad generalizations across many kinds of cancers is very difficult right now.
Does it make sense to combine them or to apply them sequentially? In other words, if somebody does not respond or develops acquired resistance to one class, to pursue another?
I would say that makes lots of sense, but we don't really know for sure yet.
Okay.
Yeah, so certainly, again, things were too early on to make direct comparisons, although overall, I think we'd all agree that the similarities in activity among the different antibodies tend to be what seems to be standing out more so than differences among the different antibodies. If you actually look in detail at the molecular partnerships and interactions, one can come up with a legitimate basis for combining an anti-PD-1 antibody with an anti-PD-L1 antibody because they're not one-to-one in their association. I don't think that there would be really any reason to use two anti-PD-1 antibodies. I think that would be redundant. But I think, some of these trials are actually coming down the pike, combining anti-PD-1 and anti-PD-L1 antibodies.
What about combinations with chemotherapy, which we're seeing combinations of these immune checkpoint inhibitors with everything, essentially, and it's frankly hard to know how much of this is just empiric because these other treatments exist or because they are really a compelling combination mechanistically. Is there reason to be hopeful that they should be integrated and could be complementary, or that they would be competing with each other?
Well, I would say, maybe I'll defer to you on like sort of the basic level, but people have advanced rationales for why chemotherapy would make sense, but my personal opinion is to date it's mostly empirical. And I'm not a huge fan of doing it. That being said, it's not wrong, and there are research questions that are open, and people have advanced rationales from the laboratory that are potentially possible, but that's again an area that we don't know for sure. Certain chemotherapies have immunologic properties that modify the immune system also, so that's where it might make sense.
I agree 100%.
Okay, good.
Really, could not have said any better.
What about, should we be concerned as we have these agents entering into clinical practice, often in pre-treated settings, both in right now in melanoma, but very, very likely, I would say, in lung cancer sometime soon, but approved in patients who are already pre-treated, and particularly with chemotherapy and lung cancer, should we be concerned that the detrimental effects or the challenge of conventional chemotherapy to the immune system will dampen the efficacy of these drugs, or has not been seen to date?
I don't think so. I think the initial experience with nivolumab in the context of patients with lung cancer, the vast majority of those patients have been treated with several lines of chemotherapy. And despite that pre-treatment, 20% of those patients responded, and some of them very durably. So I think it's evidence that chemotherapy doesn't negate the capacity for the immune system to respond to your cancer in the context of checkpoint blockade. I think that there's a few confounders there. I wonder whether chemotherapy may change the tumor in ways that may make it more immunogenic. There's that potential. You also wonder, too, about the patients that remain well enough to go through several lines of chemotherapy and still get immunotherapy as their third, fourth, or fifth option for treatment. Those patients and their tumors may be very different. And so those patients may be set up to respond well. So I think you could imagine either side in which chemotherapy beforehand could be good or bad, and I think it's an important question to try and better understand.
How commonly do you see mixed responses, an area where patients might have several different metastatic deposits and one or some of them shrink and others remain stable or even grow? And if so, if that happens, any thoughts on a potential mechanism for that?
Well, I'd say in my clinical practice of taking care of patients with melanoma, we see it relatively commonly, unfortunately. And this goes into the nuances of clinical medicine. So this is where you talk to your doctor and you figure out what you feel comfortable with in conjunction. It hasn't been discussed yet, but some patients who get ipilimumab can initially have it look like things are getting worse before they get better. And this is sort of what you're alluding to, I think. And I think it's a discussion you have to have with each patient. If the patient's well, then you can wait and see if that's going to turn into an immune response. And the patient's not well, I think you sometimes need to think about next steps.
Well, I'd be thinking of two things. One is this issue of pseudo progression, which is, I think, something that we've all been learning about, but especially as these agents go out from the centers that have done the trials and have the most experience to a broader utility with physicians who don't have that experience. It's important for doctors and patients to learn about pseudoprogression, but also the general issue that we certainly see in lung cancer of sometimes a metastatic clone having a different molecular phenotype and growing in the liver but shrinking in the lung. And I don't know if that happens ever or never or somewhat in between with these immunotherapies, where you'll actually have some clone that behaves differently, and if you biopsy it, you find it has different characteristics.
Yeah, I think this is an extremely important question to be answered, which is why in patients where you commonly see some tumors progressing and others regressing with a particular therapy, what's different between those tumors, because that's how we're going to learn how to ultimately bring it to the point where all of them are regressing. I think without question, the best opportunity to do that is an approach that's sensitive to talk about, but it's an important one to consider, which is the rapid autopsy approach. So the idea is that patients, this is obviously a very personal decision for a patient and their family, but the idea is that a patient and their family can contribute tremendously to knowledge and better therapies moving forward, even in the context of the failure of current therapies to benefit them ultimately. Actually, this is a program that Dr. Topalian has set up. And so the idea is that preferably within 6 hours of a patient passing on, is the opportunity, because it's known which of their tumors are progressing, which ones are regressing, to be able to actually look at all of them to understand what's different between the progressing and the regressing tumors. Again, it's a sensitive subject, certainly very personal for the patient and their family, but a lot of patients really do want to be able to contribute, even in the context of their own demise, to the next generation of patients.
I'll just add on to that. If you take it one step back even from there, I think there's a growing understanding that when the cancer starts to grow again after the treatment has worked, that something's different. And in lung cancer especially, they're starting to do repeat biopsies to figure out what actually is different. And that's usually done in the context of trying to identify new targets for other drugs. But I think that era is coming to immunotherapy not that long from now as well, trying to figure out what are the new antigens in the tumor that might be a different target.
I think that's an interesting point that Grace did just over a month ago, a big patient forum on acquired resistance to targeted therapies, where we we'll often see great responses that unfortunately don't last forever. And we're finally now starting 10 years after the EGFR inhibitors' first great responses to have drugs that can get the genie back in the bottle. And if you have a target that you can identify that will predict which patients are going to benefit from one next treatment or another, it makes a lot of sense to do repeat biopsies. And that's gained a lot of momentum just in the last year. There's less history right now with immunotherapies, but we shall see. What about the patients with the tail at the tail of the curve who have these durable responses? We're cautious about trying to predict how long that will be, if it's permanent or not, if we can use the term cure. Is there any way to predict partway along which of the patients are most likely to benefit, either from looking at blood or T cells or anything about their immune response 1 or 6 months in, and which patients are likely to be the best beneficiaries of these therapies?
I would say that this is an area of active research, and there we have some hints on this. I think we just need to be careful about over-interpreting them so far. I don't have any marker in my clinical practice yet that tells me it's a slam dunk and this is what's going to happen, but we have some hints, and we're going to talk about them this afternoon.
Right.
I don't want to raise them because I think they'll stick in your brain as this is the thing the doctor's got to be checking. But we have some ideas, and we're trying to figure that out more.
So thank you all very much. These were great presentations. We'll break and we'll reconvene here in about 20 minutes, okay?